So, hi, my name is Kate Wilcox. I'm an internal medicine and pediatrics resident at Medical College of Wisconsin in Milwaukee. I'm here today in my role as a fellow at CardioNerds, which is an online platform which aims to democratize cardiovascular education. Today, we're going to talk about an exciting late-breaking trial presented at AHA, the progression of atrial fibrillation after cryoablation or drug therapy trial, or progressive AF. I'm absolutely thrilled to be joined by Dr. Andrade, who is the Director of Electrophysiology at Vancouver General Hospital. He is co-chair of the Canadian Cardiovascular Society Atrial Fibrillation Guidelines Committee as well. Thank you so much for joining us, Dr. Andrade. Can you provide some context for this trial and review the question you wanted to answer with progressive AF?
Sure. So thank you very much for having me. The main question that we were trying to address with progressive AF and with the previous early AF study was really what is the best first treatment for patients with atrial fibrillation. So we were taking a population of patients who are symptomatic, who are seeking medical care to have their atrial fibrillation managed. And then we just basically randomized them to ablation or anti-arrhythmic drugs. So drugs are the standard. It's what's always been used as the first treatment for atrial fibrillation. But we viewed ablation as an intervention that's potentially disease modifying, right? Because it targets the triggers, it targets the substrate that perpetuates the atrial fibrillation, it regulates the autonomic nervous system. So our thought was if you took a more definitive treatment and provided it earlier in the patient journey, maybe you would see beneficial outcomes. And so the traditional outcomes of recurrence, quality of life, of healthcare utilization, they're all important. But the big sort of the novelty factor in what we presented yesterday at AHA was, the idea that is ablation a disease modifying therapy or is it merely a symptomatic therapy? And that was the big crux of the question and why we explored this.
Absolutely. That's helpful. Thank you. So as you mentioned, you had previously conducted the early AF trial, which also randomized participants to ablation who had not already failed anti-arrhythmic medications. Can you summarize some of the key differences between this trial and early AF?
Yeah, I mean, they're functionally complementary, right? So the early AF trial was looking at that 1-year recurrence. So it was really focused on the short term. It was focused really on, is atrial fibrillation going to come back or not? And that was the idea behind early AF. And so that endpoint is what's sort of dictated to us by the Heart Rhythm Society, the European Heart Rhythm Association, as the primary endpoint for clinical trials evaluating AF therapeutics. And so that was the focus of our study, very similar to other trials. Progressive AF is that, plus the idea of looking at what's going on in the future. And so if you're looking at AF progression, you really have to look over very long time horizons, particularly since the population of patients were otherwise young, otherwise healthy. So objectively, a group of people who are at low risk of progressing. And so you have to follow them for longer to actually see that difference. And so where early AF is short-term recurrence, progressive AF is long-term progression.
Okay, thank you. That makes a lot of sense. I was going to touch on this later, but since you mentioned it, we can just talk about the relatively young age of the cohort. They were 58 years was the median age. Can you explain sort of if that was an intentional decision or how it played into the trial design in this case?
Yeah, well, I mean, it was an intentional decision because, what we're aiming to look at and what we're aiming to deal with is people early in their patient journey, right? So if we're getting people who are older, people who have a lot more comorbidities, that's not really the same group of people that we're looking for in terms of that early first treatment population. So, we purposefully picked a group that were younger, so we're about 10 years younger than the average AF ablation trial. We picked a group that were at low comorbidity burden, and therefore at low risk of having, substantial substrate abnormalities in their heart. So really trying to get at atrial fibrillation while it's still contained to be an isolated electrical problem that would be amenable to intervention, as opposed to kind of the horse has already left the barn and we're dealing with a lot of persistent AFib as a problem.
Interesting. That makes a lot of sense. Thank you for explaining it. Were there any other main differences in eligibility criteria that you wanted to talk about compared to other trials?
Well, I think the other thing that's important to highlight is this is not first diagnosis of atrial fibrillation. So the median time from diagnosis to enrollment in the trial was about a year. That year is, compatible with something like the EAST-AF-NET trial, which showed early intervention within that first year to show benefit in terms of mortality and stroke reduction. So we're kind of in the same ballpark. But the key thing is we're not taking people at first presentation. So the patients that we enrolled, they were symptomatic, they were having lots of episodes, their quality of life was affected, and we were trying to capture them at the point of kind of needing some intervention and trying to figure out which one that should be, rather than first presentation of AFib.
Thanks. So I think we can move on to discussing kind of the primary and secondary endpoints for the trial now.
So what we saw in terms of the primary endpoint, we really focused on the view of that progression. So taking atrial fibrillation from when it's an isolated electrical problem where the episodes create structural and electrical abnormalities that lead to persistent AFib. And so the primary endpoint was recording that progression on a loop recorder. So, our study had continuous monitoring. We were recording all of the AF episodes that they were having. And so therefore we could be very definitive on the timing of when they kind of get to that point of being persistent AFib. And so in the guidelines, persistent AFib is 7 days of continuous AFib. And so we could see when that first episode happened. And what we saw was ablation had an association with a 75% reduction in that progression. So 1.9% of patients treated with ablation developed persistent AFib over the 3 years of follow-up, compared to 7.4% treated with anti-arrhythmic drugs. So really a very different progression. And you can see when you look at the Kaplan-Meier curve, how they just keep moving further and further apart the longer you're following these patients. In terms of secondary endpoints, it was not unexpected. It was very consistent with what we saw in early AF. So there was a 50% reduction in recurrence of atrial fibrillation. So this is 30 seconds of arrhythmia on continuous monitoring. We saw significant quality of life improvements at 1, 2, and 3 years. And it didn't matter if it was a disease-specific score like the effect score, if it was a generic quality of life score like the EQ-5D score, or if it was symptom status. So patients treated with ablation were half as likely to be symptomatic at 1 year, 3 times less likely to be symptomatic at 3 years. Healthcare utilization, so significant reductions in hospitalization, significantly lower rates of needing a non-protocol ablation, so the group that failed drugs and then had to cross over, or repeat ablations in the group randomized to ablation. And then lastly, the key piece of this puzzle is if we're thinking about pushing interventions earlier, interventions have risk. And so we want to know that this is a safe strategy. And I think one of the key highlights that we see is that the drugs aren't benign. The risk of any complication was reduced by 50% by having an ablation versus being on drugs for 3 years. Serious adverse events, a very similar reduction, although we didn't have power to show it statistically, but it was about a point estimate of a 50% reduction. Patients treated with drugs, all 3 strokes happened in that group. The myocardial infarctions happened in that group. The syncopal episodes, the new onset heart failure, all of the adverse outcomes of significance really happened in the group treated with drugs rather than the group treated with ablation.
Really interesting. Overall, really exciting results and really significant, obviously, which you mentioned. Just going back to kind of what you were saying about the anti-arrhythmic medication group, I noticed most of the patients in that arm received flecainide as the first medication. What was the discussion behind the designing the protocol for anti-arrhythmic drug choice?
Yeah, I mean, practically speaking, the way we did it was just what the guidelines say you can use. We didn't favor one over the other, with the exception of amiodarone was not considered a first-line therapy for this group. So in young, healthy people, you don't want to commit them to long-term amiodarone. But in Canada, we have available flecainide, propafenone in terms of class 1Cs, sotalol and dronedarone in terms of our class 3s. And we left it to clinicians to decide to use whatever they wanted to use. We did protocolize how these drugs should be initiated, how they should be monitored, how they should be titrated, how they should be discontinued, that protocol was very kind of prescriptive, but we didn't tell people what to use out of those 4 choices. Now, the protocols are available in the old American Heart Journal methods paper. They're part of the supplement. So anyone who wants to, have an objective way about initiating and titrating antiarrhythmic drugs is welcome to use those. But we were very sort of strict in ensuring that when patients left the blanking period, when we were going to start evaluating an endpoint, that they had to be on a therapeutic drug at that point.
That makes a lot of sense. I think the question we're always asking with exciting trials like this is how it will change practice. Is there one? I know it's a lot to boil down a big trial with a lot of information in it like this one, but is there one takeaway you would want cardiologists to have from this trial?
Yeah, so I think what progressive AF really shows us, and early AF together, is drugs treat the symptoms, but ablation treats the disease. And I think that's the first time that we're really seeing that in a clear manner, in a population of patients who are at low risk of progression. They did not progress. Whereas if they had drugs, they continued to progress along, which means that nothing's changing in the background.
EP is such an exciting field currently, and there's a growing body of evidence surrounding the treatment of atrial arrhythmias. What should we be on the lookout for next in AFib research?
With AFib research, there's always going to be the questions around, the best techniques to do procedures, how we can make the procedures safer, how we can make them more effective. So those refinements will always come. There's always going to be guidance on, how to modify risk factors and treat the underlying myopathy. I think that there's kind of 2 strategies, or at least 2 branches in what we're talking about. Most of this refinement piece is really once it's already established itself. And that's where we get into the difficulty, because the evidence for ablation procedures and what to do is less clear. That's where we start to see the difficulties of interpreting the results of older studies like AFFIRM in light of the newer studies. Whereas in that early phase, when it really is an electrical problem, when it is something that we are able to intervene on, that's the time where we should be more focused on preventing it from ever getting worse, stopping the atrial fibrillation before it can cause heart failure, stopping the atrial fibrillation before it can cause a stroke. But once it's persistent, mortality goes up by 1/3, strokes go up by 1/3, heart failure incidence goes up. So if we can get on it earlier, we can contain it at a time when it's more treatable, and we can see those long-term benefits.
Overall, this has been a really incredible discussion of a really remarkable trial, and I can't thank you enough for taking the time to discuss it with us. It's been a lot of fun talking with you.
No problem. It's my pleasure.